like this is always so bizarre to me how we should probably get started because like how broad a topic they give you to have in 45 minutes. So we're supposed to talk about large bowel obstructions and colitis. So that's like ischemic colitis, infectious colitis, ulcerative colitis, Crohn's. So that's a lot. So I figured I would kind of talk about things that I feel like, we don't see all the time. So so infectious colitis, I was going to at least get to that and then we'll see what we can get through. But I wanted to make sure to go through some of the questions because I went through your question bank and there's definitely one question that's like wrong. I think Rachel Cox, you're at Conway. Hey, did you were at least yesterday you were the only one. Did you see that big wrong question? Oh, well, we'll talk about it. Oh, well. Don't worry about it. Whatever. Okay. Okay. So infectious colitis. Why do we care? Because you get consulted for these things, and it's always in your differential. Like Crohn's disease can look like some of it. Crohn's colitis. Oh, sorry, Rachel. Sorry. Where are they? Is that a new room?
No, they usually get it every day.
No, they did it.
Like, put up a different wall or oriented it in a different direction?
No, it's just they moved the table.
Yeah,
they oriented it. Because it's narrow.
Oh, yeah.
And they painted it.
Yeah.
Oh. Whoa, mind blown. There's that phone, though, the one that never works. So the complications of surgery, like C. diff, colitis, etc. And they can progress to the point of needing surgery, and so we care. So before I go, can you think of the infectious colitis etiology? So Campylobacter, that says jejuni, but coli, that can be one. What are some other ones? C. diff, exactly. Salmonella. Yeah, that's salmonella is the typhus. But CMV, colitis. I know, and I didn't even get into the viral ones. I just golly, but how do you treat that gang cyclovir? And that's what do they say? The inclusion bodies. Those are the key words. CMV colitis, inclusion bodies, gang cyclovir. And it's going to be immunocompromised patient. And they present with diarrhea. So, but these are infectious colitis is what I'm talking about. So Campylobacter. It's a gram-positive rod. I've had that on mixing up board exams, but that was a test or a question. I tried to put pictures up here. It's kind of, on endoscopy, it's just inflamed mucosa. The key here is they'll have bloody diarrhea, as opposed to with C. diff, it'll just be watery diarrhea. So bloody diarrhea and dark field microscopy is an aid in the diagnosis. So that just means they look at it under the microscope and they can see the actual little organisms. And you treat it with Cipro. And then Yersinia. So these are younger patients. This one I think is important because it does mimic Crohn's disease. So in the stem of the question, it'll talk about something that might sound like Crohn's because it's a younger patient. It's in the terminal ileum. It's like kind of nodular mucosal pattern. You get ulcerations, and this is why it's important to get stool cultures, and because eventually in your career you're going to diagnose this, and you treat it with Bactrim or like an aminoglycoside, but Bactrim's a safe way to go. And then Salmonella. This, we talk about the endotoxins with Salmonella. That's always potentially a question. And they can get really sick with this. Also, you'll hear about it in context of gangrenous cholecystitis. And these patients also have bloody diarrhea. And you make sure, and you treat it with fluoroquinolone or like Rocephin, a third generation cephalosporin. And I've not seen one, but they had one of these like right before I started my fellowship. So you will see this every now and then. And the patient perforated, and so they resected the colon. And and you can divert proximal to. That's kind of a management even for C. diff colitis. That's sort of if you do a loop ileostomy, that can really help distally. And so sometimes if the patient's too sick, that's an option. So C. diff colitis, this is gram-positive. That's why we treat it with vancomycin. And to me, it's impressive that it was only identified in 1978. That's crazy to me. So there are two forms. There's the active form and the inactive form. And the active form, that's difficult to culture, and it doesn't survive as long as the inactive form, which are spores, which makes sense that that's what would survive longer. And that's why it's those spores that are the reason you have to mechanically wash your hands with soap and water, because you need to rinse the spores off, and the alcohol prep if the wall doesn't work. That was on the AB site for sure. They said, they presented this patient and what is the proper hand washing technique or something, and it was not. And they gave all this alcohol containing hand wash and then non-alcohol containing stuff and but it had to be soap and water. So the active form, it's normally suppressed in the colon, but if you are on antibiotics and you kill off the other bacteria in the gut, then it will kind of allow the C. diff to flourish. And historically, we'd always talk about that with Clinda, but it could be any. And it's those toxins that cause diarrhea. There's the two toxins. Toxin A is the enterotoxin, and I remember this because it is not alphabetical order. Enterotoxin comes after cytotoxin. A comes after B or before B. So it's it's the other one's the other one, like Goldman used to say. So this one directly leads to colitis, and it binds on the glycoprotein receptors on the colonocyte. And it's a chemoattractant for neutrophils and activates macrophages and mast cells. So it's this ramped up inflammatory cycle, and that's why you get those systemic symptoms of sepsis. And then toxin B, which is the cytotoxin, and this can even lead to colitis even without toxin A, and it's the more potent one. So, anyways, very testable. Colitis, it typically is associated with some prior antibiotic use. It can be classically like somebody who's been hospitalized or a nursing home patient, even if they've not been on antibiotics. Anybody institutionalized, like at Brentwood and something like that. Older patients on PPIs, that's a risk factor. Exactly, it was, classically we talk about clindamycin, but it can be all sorts of antibiotics. But it can be a long time. A quarter of them can be up to 10 weeks after they've been on antibiotics. So, several months. So you've got to go far back in their history if you want to really dig into things. So it's this pathway, you get diarrhea. It can be self-limiting, and that can progress to pseudomembranous colitis, which then could progress to toxic megacolon, which could progress to fulminant colitis. And typically it's crampy abdominal pain, and it with watery diarrhea, and it smells bad. I know that the more senior residents know that. And they definitely get leukocytosis. You'll see that in-house. If their white count's normal with diarrhea, it's almost certainly not C. diff. So watery diarrhea. In order to send for, you have to, we'll write, okay, collect stool to rule out C. diff. And if the patient doesn't poop, answers your question, but But you've got to be able, it's got to be liquid stool. It can't be solid stool. So if they're like, oh, we gathered up a big old solid stool, they can't run it. So, but it's, and this is a picture of the pseudomembranes. It looks like thrush to me. That's how I kind of remember it. And don't you love these things? It's from pretty much just a quarter to all patients. So what a great range there. And so if it's a mild, and these are the ones we don't see. Like GI doctors see this, family medicine primary people see this. You just kind of stop things and support them. Sorry, Conway, we lost you. And then, and that's a big question. Like, what's your first line treatment for C. diff? Let's see, Stacy, because you're so kind of.
Now it's oral vancomycin.
For first line.
Last it was IV or oral vancomycin.
And which is funny because SCORE starts with Flagyl, but whatever. So I'm really not sure on your, but I don't think that will be a differentiated thing in your ABSITE, but it will be oral vancomycin. And like, how do you, because I remember on your test you think, oh, how do I remember, like Flagyl, is it the Flagyl that's IV or PO, or is it, or the Vanc? And so I just remembered Flagyl, although metronidazole doesn't, but Flagyl doesn't have an O in it, so it doesn't have to strictly be PO, but vancomycin does have an O in it. I don't know. I should have talked more about fecal transplant, because that is, I meant to go into that more, because that is sort of a growing area of accepted treatment. But it's pretty gross because a lot of times will put it down the NG tube. So anyways, I think that's pretty gross. To me that seemed a little bit better, but they get it from family members. So basically, if they have toxic megacolon, it's indicated for a total colectomy. You don't have to go down and take out the rectum, just a total abdominal colectomy with diversion. They're sick. As you can see, mortality is greater than 50%. And probiotics, there is data that shows that it might, it's kind of equivocal, but decrease the incidence of antibiotic diarrhea. This is concomitant while you're taking antibiotics and afterwards. Anyways, and clinically you can add it to if you're treating people with C. diff colitis and it's a recurrent episode, think about starting them on probiotics. So I've never seen this anywhere, but these are the sort of the more aggressive forms, and they don't respond as well to management, and they and lead more towards megacolon. So it's a little early in the morning. I can't think. So yeah, this is hand washing, vigorous hand washing. You got to get the spores off. And that's why you have such outbreaks in nursing homes and in hospital rooms. And you'll notice particular units will have outbreaks, and you've got to go through sort of a terminal clean because the spores can survive for a long time. And obviously, just good antibiotic management. Make sure that it's always in the back of your mind. And then PPIs lead to a little bit more susceptibility to developing C. diff colitis. So just be mindful of who you're giving them to. It's not just everybody. They've got to be truly indicated. And so large bowel obstructions, I kind of wanted to talk about this. What are some etiologies of large bowel obstructions? Tyler.
Etiologies, cancer, masses, volvulus.
So you say cancer masses. What? So cancer, but So, okay, well, just cancer. And then, I'm just gonna go into something else, but,
Oh.
so like an extrinsic mass, I guess you could say, is that, maybe that's what you're saying. Okay.
Volvulus,
Uh-huh. And which kind of volvulus?
sigmoid.
Okay. And cecal. Okay.
Strictures from like inflammatory bowel disease.
Diverticulitis, etc. So, and Hirschsprung's, Ogilvy's, you have to always have that in the back of your mind. So I think it's hard for me to, they'll show you an x-ray and ask you kind of what's the management of this patient. So this here is a sigmoid volvulus. For me, it's sometimes hard to tell the difference, and I know that sounds crazy, but it is sigmoid versus cecal. Cecal, I think I see small bowel more, dilated, and cecal volvulus. So that's something. So this one is cecal, and so obviously there's small bowel dilation here also, and because you can see this. But they say, oh, it's in the opposite quadrant of where, but this isn't really in the opposite quadrant of the CPAP. And sometimes you'll have a bascule, which will be up in the upper quadrant, so which can look a lot like a sigmoid. But the classic presentation of a sigmoid volvulus is, nursing home patient or just an older patient who has maybe a chronic history of constipation, and then, so what is your management of a sigmoid volvulus, Jen, Kim?
Rigid scope and bleeding orifices. They're stable enough.
And it's the key is to make sure they don't have an acute abdomen or anything before you do that. But yes, and so decompression. Look at the colon wall, and then what?
Be planned for a sigmoid.
Okay. And why do we detorse it initially?
Because it can necrose.
It can necrose, but why don't we just go to the operating room on everybody?
It's time for resuscitation.
That does give you time for resuscitation.
Risk of neurotomy when entering asthma.
I've not seen any data that show, but you can maybe think because it's so distant. Well, the reason is so you can really hook them up. A lot of these patients are old and sickly, and you don't want to be hooking up like a distended upstream bowel to the downstream. So we decompress them and allow us to resuscitate, and then we can get an abdomen earlier or easier. But it's also so you can at least entertain the idea of reanastomosing. But yes. It really, do you know the percent of patients that recur a sigmoid volvulus if you were not to operate on or take out the sigmoid? It's very high. It's like 3/4, something like that, or 50%. And so, and you'll see that when you go into the operating room and you detors them, it wants to go back. And so you can imagine once you detors it's going to happen again. And so, what surgery do you do for a sigmoid volvulus? Jean-Luc.
Sigmoidectomy.
And is it like an anatomic
Yes, I guess you would. It depends on.
So it's one of those times where you don't really have to do a colon cancer operation. And so you really just take out what's redundant. You don't want to mobilize. It's unusual in that regard because you don't want things to be floppy. That's the whole problem. And so you just take out what's getting. And my dumb self, the very first one of these I did, it's actually on a young girl. It's very unusual. She was like 30 and she kept having recurrent sigmoid volvulus. And I took out too much, and I had to like mobilize all this stuff. I was so dumb, because don't get just enough that they fall right into each other, and you do your anastomosis. Anyways, So, trying to think of anything else with sigmoid volvulus.
These images are on the oral boards.
Absolutely.
They'll give it, they will present like the scenario and then show you this is the KUB.
And that's what's tricky to me is that they have you differentiate between
Right.
a cecal and a sigmoid volvulus.
So now it's, they're putting it on a laptop because they're more advanced. They, rather than a Polaroid image, they put it on a laptop now. So they'll show it to you on the laptop.
Yeah.
Stupid question.
No.
The sigmoid, we're sitting here trying to figure out, so the coffee bean sign usually points toward the direction,
And
and that's
the-
pointing the opposite way.
And that's what I mean, like, to me, I don't get what they mean by that, because it can be, that's, because, they say it's in the the opposite quadrant with the pointing down to wherever the pathology is, but I don't see that. To me, I just don't see that. I don't know what they're talking about when they tell me that. So that's why it helps me to see the dilated small bowel, which would be more with cecal volvulus. And I will say, so you're like, oh, this is sigmoid in the opposite quadrant. Left lower quadrant is the pathology, right upper quadrant is the, you can see the dilation. But this is pretty dilated in the right upper quadrant, so that's confusing to me. I don't know if anybody else has some pearls that, but.
I mean, I think it's just, they're not gonna try to trick you. I think they're gonna give you the conventional for the sigmoid volvulus, where you do see that, and it like really points them to the right upper quadrant. But in practical or in real life, it may not always present that way. I think
Boy,
it's-
howdy. And in real life, people, like even radiologists will disagree, like, so, but there are times where it's very clearly, this is very clearly sigmoid as opposed to cecal. So they're gonna always put on their sigmoidopexy as an option. That's wrong, we used to do that, and then we learned that it just still happens. Oh, and the other, the etiology is that it's a narrow-based mesentery. And so, sometimes you see people's mesentery as it comes off of the aorta, it's really broad and kind of, and you can imagine that it's like I think the classic picture is like the blimp. And if you have it fixed in 2 points far apart, then it's not going to spin around in the wind. But if the 2 parts are much more narrow and close together, so that's what people say is the etiology of short. So broad-based mesentery is protective. So cecal volvulus, what's the difference in management of cecal volvulus as a sigmoid?
Straight to the floor.
Exactly. There's no role for decompression with colonoscope or rigid procto or anything like that. Yes. So, and it's younger patients too. So it'll be like a 40-year-old man comes in with constipation or, an obstruction, and he's nauseated, and you get this x-ray here, and what's the next step? And they're gonna have like endoscopic decompression, rigid sigmoidal proctoscope, and then go to the operating room. And what surgery do you do there? Again, it's not a cecopexy, it's a right colectomy. Okay, there's that. And then I was going to talk to you, why do I even, do we have time? There's so much.
Oh, and something else I've seen about this written places, they might ask which one of these has earlier vascular compromise, and it's always the sequence is the answer.
And I remember that because I was at the VA when I saw my first one, and I was thinking of all the ones to have at the VA because it took so long to get to the operating room. Ulcerative colitis. Okay, I'm going to give myself 6 minutes to go through this. So we did a Crohn's case yesterday, and it's, we're doing this big operation, and it was frustrating because surgery is not curative. However, with ulcerative colitis, you cure ulcerative colitis with surgery. So that is satisfying. That being said, If it's an indeterminate colitis, that sucks because it actually might be Crohn's, and you do this beautiful pouch and everything, and it turns out it's Crohn's, and they have a horrible life. With Crohn's colitis, surgery might not be curative. In fact, it's not really, it's truly a medical disease, but recurrence in the pouch can be disastrous, so you make this beautiful pouch thinking it's ulcerative colitis. Every now and then, you'll get talked into somebody getting a pouch for what you know is Crohn's. Don't say this on your board exam, but because they've never had any other extracolonic manifestations of Crohn's, and it's been such stable disease, and they have this and ileostomy, and we did one of my fellowship, and we'll see. I mentioned that here, and Grimes thought I was insane, but whatever. So really, 10 to 20% of patients' colitis is indeterminate. You're really not too sure if it's UC or Crohn's, and so in those patients, we don't dive in and do a pouch. So indications for surgery, it's pretty obvious when it's emergent, like if they have an acute abdomen, a megacolon, or if they're perforated. Those are the emergent indications. The elective ones can be a little bit more tricky. There's, and this is for ulcerative colitis. There's the risk reduction for cancer. So it used to be, we'd say once people had UC for 10 years or so, you needed to start talking about getting the colon out because there's this risk of colon cancer developing. And the tricky thing with UC patients' cancers is that it doesn't come through the typical polyp pathway. So you don't have that 10-year leeway time where you find a polyp and just take care of the polyps and stuff. It comes about de novo. So it's not going to be a little polyp that then turns into a cancer. But it's kind of out of vogue, the elective resection just for risk reduction, because it is still a low risk of cancer, and we have fairly good management.
You are the first person to join the conference.
So dysplasia. So when you go and you're scoping patient, and GI is really the people that did these scopes, but you have to know you go. And I think the current in vogue is every 10 centimeter? This changes, so bear with me. And it depends on if you do colorectal literature or general surgery literature. But and you take circumferential biopsies like every 10 centimeters. Some people say in every portion of the colon, so the rectum, the sigmoid, the descending, the transverse, and you go, and what you're looking for, it's not like, oh, is there going to be a cancer where it doesn't look, you'll see a cancer, it's dysplasia. And dysplasia, it looks, erythematous in that area. And so if the bowel looks totally normal, you still biopsy it, but it's pretty likely that it's not going to be dysplastic. But and in the and so they're going to tell you if it's low grade or high grade dysplasia. The other thing that it's a bit more difficult to determine when to operate on people is if it's just difficult to manage their UC, like when you pull the cord. And the other thing that's annoying with this is if it's difficult to manage their UC, that means they're not taking a diet well, they're having many bloody bowel movements a day, they're getting more and more deconditioned, they're having to be on steroids, all this stuff. So that patient's looking even less like an operative candidate. And so sometimes you just have to stop the madness and operate on them, even though you're like, well, let's improve them, before we go to the operating room. But sometimes you have to call it what it is. They're not improving, no matter what their medical management has been. And so you just have to pull the cord. So the big question is, excuse me. Yes.
Sorry, it went too late, I think.
Okay. And so the extra-intestinal manifestations that can be addressed with the colectomy, the thromboembolic, I missed a beat, the erythema nodosum, and the hemolytic anemia, the arthralgias. What are not typically helped are the pyoderma gangrenosum, ankylosing spondylitis, arthritis, and the PSC, primary sclerosing cholangitis.
It's just so much on the written
It
boards.
is. These are, so you do a colectomy, and those are the ones that do not. And so what are so a proctocolectomy is curative, and it's the gold standard. Whether or not you create, or you do a restorative proctocolectomy, or a diverting stoma, it's up to lots of factors, and it's all in conversation with the patient. If they are motivated and fairly fit, and they are not 70 years old, you'll talk about doing a pouch on them, and you have to discuss childbearing plans with women, because deep down, once you get into that pelvis, a third of them will have fertility issues, and so we wrap everything in separate film, and we do as much as we can, but sometimes we'll postpone the pouch until after she's had children. You also have to take into consideration patients with an ileostomy who then get pregnant, or they have a big old belly, but that's still okay. It's still okay, but it's just it used to be a big consideration. Like, how do we manage this? But with ileostomies, they'll do okay, but we typically will reserve restoration with a pouch for after when she's conceived and had her family. What's a situation where you would only do a total abdominal colectomy, leaving the rectum in situ? Chad Brady.
Toxic intercourse.
Yeah, so when they're just too sick, you get in, get out, and you divert with the end ileostomy. So we talk about 2-stage and 3-stage and 1-stage surgeries for ulcerative colitis. What's a 1-stage? That's where you do a total proctocolectomy with a pouch, no diverting ileostomy or anything, and that's when it's completely elective, young, healthy patient, everything looks perfect. We don't do those a lot of the time. Some patient centers don't do them at all. A 2-stage is where you do a total proctocolectomy, restore with the pouch, but you divert with a loop upstream. And that's when they're stable and you're doing well, but you're a sane surgeon and you don't, and so you're just protecting that pouch while it heals. Because when they leak, it's disastrous. And then, and you have long staple lines. And then you have a 3-stage, which is where you do the total abdominal colectomy initially. And the advantage of that, for one, is the pelvis stays uninterrupted. And so when you finally do go do the proctectomy, it's like a virgin pelvis. It's easier to get in. And the other advantage is that when they're so sick, operating the pelvis is difficult, and there's a lot of complications with that. And so you just get in, get out, and then you go back and you do the restoration, or the restoration with a pouch and a diversion, and then you can go in and take down the ileostomy. So what are some options? This is all over your boards. So if you go down to make the pouch and you can't get it to reach, this is really enough. This is like chief question. So Chad, maybe Patton, you and
I
Chief.
scored the mesentery, trying to people.
Could score the mesentery. That's one thing. What else can you do?
So take
I get to re-articulate.
So this is for the small bowel.
Oh, for small bowel.
Because we're bringing the pouch down, but you're right. Yeah, let's go with these. So this is for if you're trying to get the colon to reach. So colon to reach, exactly. You divide the IMV. That'll help. What else? So you can divide the IMV. You can score the mesentery. You take down the splenic flexure. You can, the other thing is you can rotate it counterclockwise, and you can come through the small bowel mesentery, and that to the right of the SMA. So what are some other, so for a pouch specifically, so you mobilize, and this is on your board exam, so you mobilize all the way up to the duodenum. So that's one thing people won't do. So make sure that your mesentery is mobilized. And we do this sometimes when we're creating a ileocolic anastomosis. Sometimes we do it for fun because it's really fun and just get all the way up there. But, and you'll just, next time we're in the operating room, well, I'll show you guys how, just make sure you're all the way up to the duodenum. That's one way. What else can you do? Score the mesentery. You do that. Another thing you can do is you create the pouch and you just leave it in the pelvis and you divert with an ileostomy. And then you have them go lose weight and all the, any other thing, and you come back later and it will have elongated in theory. And so that's the last ditch effort, is that you create the pouch, you leave it down there. Because what's your option is you bring up an end ileostomy and they don't get, they don't get the planned operation. So that's one thing you can do. And really, you do need to counsel patients about, you might not come out of here with the pouch this first trip to the operating room, because it's pretty tricky. So I wanted to go through some of these questions before you guys get to them, because when I went through them in planning this lecture, there was one that was just objectively wrong. And I didn't want to confuse you guys. So, so here's one question. Is a 60-year-old admitted to the ICU with abdominal pain and diarrhea after being on antibiotics for pneumonia? Bang. What is it? Okay, there's all these other words in here, and you can read it to make sure there's not a curveball, but C. diff is the first thing that comes to your mind. What would it be then? So endoscopy of the colon reveals the following, and it looks like fresh. It's pseudocolitis to me. So she was started on IV flagyl, and she's worsening. So what's your next step in management? PO vanc, exactly. And I remember PO because vanco. Okay. So that one is good. This one is the wrong question. I'm going to read you the wrong question and tell me. So, 45-year-old woman with a history of Crohn's presents with abdominal pain. The patient has diffuse peritonitis on exam. She is febrile to 102 and tachycardic to the 130s and hypotensive. White count is 13,000. CT scan shows a dilated cecum with ascending and transverse colitis. What is the operative management that's most appropriate for this patient? So they're trying to describe to you, they're describing a septic patient who obviously needs to go to the operating room because they say peritonitis and all of the other vitals. But with Crohn's disease, it's a little bit more, it's not as straightforward. They mean ulcerative colitis. They want you to think ulcerative colitis, and that is a subtotal colectomy of ileostomy. So this UC patient comes in with a toxic megacolon and a toxic appearance. You go to the operating room and you don't do a proctocolectomy, you just do the abdominal colectomy with an ileostomy. That's because all the other options, they say a loop ileostomy, total proctocolectomy with pouch, and et cetera. You're not going to do that emergently. Okay, a 35-year-old man presents to the emergency department with a one-day history of abdominal pain. It's worsening. He's noticed difficulty with bowel movements over the last month with increasing blood per rectum. He has a history of UC. He is noted to have significant abdominal distension. He's tender with guarding. He's tachycardic. Blood pressure is 95/60. White count is 17,000, and he's febrile. The CT scan shows an inflammatory mass in the descending colon with diffuse colonic thickening. So this patient is sick, needs to go to the operating room. He has ulcerative colitis, and he has a mass in the descending colon. They want to know, what are you going to do in the operating room with this patient? Actually, they say, what do you do next? And some of the answers are like ICU and resuscitate. Go to the operating room, but what are you going to do for this total abdominal colectomy? Again, it's the same concept. Don't do the proctectomy and it's UC. Don't just do a resection of this patient has lost the right to having a colon. So colon's going. Okay, I think we have to be done. But but at least we went through the question that's just wrong. And SCORE apparently knows about it. I talked to them. We're changing it. We're fixing it. Okay.